Welcome, everyone. I'm Rachel Bensen, one of our pediatric IBD doctors. We are so happy to have you join us again today. We've been working closely amongst our team and with our Family Advisory Council and hearing feedback from many of you, and heard that there were ongoing questions and there was interest in having another discussion like this. So we're happy to have you, and we're very grateful to have our infectious disease colleagues join us today to help provide some more information to you on COVID and IBD and living with it in our community. Also want to always share the caveat that this information is always changing. We give you information as up to date as we can, but please keep in mind that it's always an evolving picture and always changing. Maybe Megan, can you advance? So our objectives today, so we'll have some brief updates regarding COVID in children, COVID in our region, and COVID specifically for youth with IBD. Briefly touch on a little bit about what kind of testing we have available, vaccines and their development and how they're relevant for you, and then talk a bit more about those considerations about returning to school and college. Throughout, there's a Q&A section in the bottom of your Zoom, so please send in your questions, comments, thoughts, and we'll do our best to address them as quickly and then completely as we can. To let you know who we have here from our team. I don't know if folks want to introduce themselves, but briefly, we have primarily our IBD physicians, nurse practitioners, nurse coordinator, and research coordinator, and Dr. Sharon Chen and Hayley Gans, who are from infectious disease, in particular from our infectious disease program for immunocompromised children that we partner with closely in general, and in particular now on issues related to COVID.
So thank you for that introduction, Rachel, and welcome everybody. We're thrilled to be back here, and if there isn't something that we're actually covering specific to your questions in our talk, please do, as Dr. Bensen said, please do use the Q&A system, and we'll do our best to really cover what it is that's on your minds today. And of course, I know your team is always available to you to answer any questions, obviously, around that. We wanted to spend just a little time going over some of the basics, because I think that there's a lot of information available to people, and sometimes it can be very confusing and sensationalized. And I just want to put things into perspective today. So I just really want to go back to what coronavirus is, because I'm not sure that everyone completely understands the virus itself. So like most viruses, it looks like this, and it has things sticking out on from this membrane, and actually these are proteins that your body can recognize, and also what the virus can use to enter into your body. It's important to know that it does enter through your mucosal surfaces, so that's why there's a lot of attention to not touching your face, not touching your mouth, your nose, your eyes. So there are receptors in all of your membranes that allows the virus to enter. So just to know that is a really good thing to know. The other thing to know that is, as far as viruses go, these are actually large. And the important thing to know also is that they're actually stable. So what that means is as they go through their life cycle, like all things have to, so that they can make more of themselves, they don't change at the rate that other viruses do, because they have some corrector features to them, such as differences influenza virus, which does change pretty rapidly, and we all know we have to get immunized every year against that to account for that. There are 4 types of coronaviruses that circulate annually, so we are very used to this group of viruses. It's a large group of viruses, 4 of which circulate every year and give us the common cold. And then there's these three that have really come into attention over sort of starting in 2003. And that was the first outbreak of this kind of coronavirus, which is a little bit different than the four that circulate every year. The first one, you probably have heard the name, SARS-CoV, and that transiently circulated. It caused a lot of death in people, unfortunately, but it wasn't very widespread. That was followed by another coronavirus called MERS. That one also caused death in people that had infected at a high rate, but it didn't circulate globally. And then we come to our 2019 coronavirus, which is new to us and is infecting humans at this time, and obviously is very widespread and is very contagious. And so we know that all of these viruses, though, can give you a spectrum of disease, and we'll talk a little bit about that. So what is the spectrum of disease? That people who are infected with the current coronavirus, what we understand now is that you either have, in the majority of the people, so up to 85%, you have no or mild symptoms. So you might feel like you have a little cold, like you would with a common cold that comes around every year. So that spectrum is seen with other coronaviruses as well. 13% of people are symptomatic, and so it will have a range of symptoms, whether it's not, they have muscle aches or fevers or other symptoms such as cough and diarrhea. And a subset of those obviously will be ill enough with their symptoms to go to the hospital and need some further care. Severe disease is really only seen in 2% of people who are infected with this. And so obviously this group of individuals is the group that we tend to associate with the mortality rate that we're seeing. So I just did want to point out that group that does have enough symptoms to get hospitalized is largely in our elderly population. And this is the population that we really do need to protect at this time. They're very susceptible to poor outcomes once they are infected with this virus. So that's the group that we really want to protect. And you can see here the steep curve, 65 and over. The 50 to 64-year-olds, most of those individuals do just fine unless they actually have a predisposing condition that would actually cause them to have more severe disease. And you can see our young individuals really are spared the severity of the disease, and that's a little bit different than other viruses such as influenza that circulates, because influenza does actually cause severe disease in our very young. So we need to protect them from that. This one is not the case. And again, in the young population, that 18 to 49 who get into the hospital, they don't actually tend to have poor outcomes even at that stage. So where are we? We had sort of previously said this is very highly contagious, and we can see, we know that it started in a couple of hotspots, but it's really actually spread throughout the globe. And you can see here, this blue is indicating new cases, and we're these are the numbers from today, and obviously there's just global spread. So this is why we call it a pandemic. It is globally spreading within all of these communities. So let's talk a little bit about, now these are slightly older numbers, but we know that the world, we saw it at up to 18 million, and the US is now higher than this, but this just shows you that the US actually has the bulk of the cases now at this time. And just to give you a little bit of sense of in a snapshot of people who are being tested in the US, there's 4 million as this count, about 5% are positive. And so that really speaks to the fact that, yes, 5% have actually seen the disease and are infected with it, but 95% of our population is still susceptible. So what that means is that the virus really can spread quite a bit, even at this time. You can see here that about 2% get hospitalized, and that's what that indicates. I did want to spend just a moment on trends, because I think trends are really important, and I know we're all getting sort of tired of this current state, but unfortunately, the daily newly cases continue to go up, and we'll talk about how nationally that's true. We've gotten some of our states now are starting to flatten the curve again, but you can see that we really never got it fully in control in our country, and then we opened up and now we're increasing. The good news is that flattening that happened at the beginning for us when we weren't overwhelmed by cases actually allowed us to gain some information that we needed to help treat it and have better outcomes. You can see here, while the daily new cases go up, the daily death rate actually is going down, and that's good news for us. That's due to the greater understanding of effective treatments. It's also due to a shift in age group. So initially our young were very quarantined, and now they're the ones who are accounting for most of the cases. And as I said, they actually don't have the poor outcomes. Just to give you some information regarding what's happening in Santa Clara County, we can see here that the trends have been the same. We really actually were the first of the counties to go into lockdown, and we did pretty well, but we didn't actually allow the disease to go away. And so while we did well initially, we were in lockdown, we really opened up starting in Memorial Day, and you can see what happened here. Our cases just went up. We've now actually gone to some more of the restrictions again. You can see the counts start going down, and the mortality rate has done just what it did nationally, but we actually have had very few fatalities as of late. And just to give you some trends of how they were impacted by closures and openings, you can see here these dots along the top, the red, are when there were actually mandates. So we closed pretty early, where you see these red dots in March, and we really kept a slight plateau. We opened up starting with these red dots in May, and you can see we quickly rose, and now we've had 2 additional shutdowns that you can see here in July, and we're starting to drop our curve again. So while I know these are painful, you can see really how they impact our cases and how important they are. This also is influenced by masking. So we are one of the states that has a broader masking mandate, but it's not everywhere, and where it isn't, the cases are continuing to go up. This is just some data regarding testing. I pointed out that within the US, the test positive rate is about 5%. We're at that now. We had remained at around 2% until recently, where Santa Clara County is now at about 4% of those who are being tested are positive for the virus. Just to talk a little bit about who actually is getting sick. So you can see here that actually the majority of cases are in people 18 to 59 years of age. What's a little bit different is that while the majority of cases is not in our older individuals, the majority of the deaths are. So it just gives you an idea of who we really need to protect. And it's this group who is having all the infections that actually will be the ones who are allowing our susceptible populations to get infected. The story in children, we had discussed a little bit. So this was a study that was done out of our Centers of Disease Control. This was one of the larger populations that have looked at 2,500 children were accounted for in the positive population, which is only about 1.7% of all the positive cases. And you can see here where they are. They're actually in our older adolescent group. And so, of course, they act more like the adult population. The receptor where the virus enters is actually fold different, so decreased in younger children. So they don't actually have the number of receptors that older children and adults do. So that accounts for some of the reason why they're not getting infected at the same rates. And then just to give you an idea of what the disease looks like in children compared to adults, while some of the symptoms are fairly common throughout, what you can see is that fever is more common in adults, not in children. Children end up having not a lot of symptoms. Cough is much more common in adults. Part of the process that's more common in children and is probably something that is something that this group should think about is actually the GI symptomatology. That's more common in children, and definitely more common in children who have underlying gastrointestinal pathologies. I did want to briefly talk about the multi-system inflammatory syndrome that has been documented in children called MIS-C. It is associated with coronavirus. I know people have heard about this on the news. It's been sensationalized. We have seen it around our country. We have seen it in London, in England, where it was first actually brought to attention, and then New York City. Here are the fevers. There's been over 300 cases, and by and large, the majority of children all recover, despite this being a highly inflammatory and symptomatic disease. I list the symptoms there just so you have them. The rates are approximately 0.002% of infected children will develop this. So it's very rare, but it does happen. And we have all been studying it and how to treat it, and most children do just fine. So what is the testing? I know Dr. Bensen mentioned some of this, and we want to know what's particular to you so we can answer more specific questions if they come up. How do we detect the virus? So when a person is sick, we actually look for the presence of the virus in different body fluids. So if you were to become sick and get tested, we would probably look in your nose. That's the most sensitive place for us to get it from and isolate it from. And what we're looking for is viral particles. And this is done by what's called a PCR. So you may have heard that term. The problem is this shows us the presence of the virus. We have no idea if that virus actually could grow in another person. So we don't know if it's infectious, we just know it's present. And virus can be present and not viable, which is what we call that process where we can't grow it. So this study doesn't tell us that. They just say plus or minus present. Another way of looking for it, and it's very hard to grow, and that's not a common test that we're going to be doing for people, so this will be how we detect it in people who are actively infected. Another way we can actually look to see if somebody has been infected or is currently infected is by looking at how the body is responding to that infection. And it's a little bit complicated for viruses, but one of the easiest ways that we can access your immune system or your response to this virus is by looking for what we call antibodies. So antibodies are one part of your immune system that shows us that you have been exposed to something. And it is one arm of your immune system that we'd like to see in place to make sure that if you're going to be reinfected with it, that you would have some response to protect yourself from that. So we do have the ability to look for antibodies. The problem is that these come up slowly. So you're infected with a virus. We can detect it in your body by PCR. And then your body over time will start responding to it. So these start becoming present somewhere probably in the second week. Some people, low numbers, have it in the first week. By about day 21 of after infection, most people will have antibodies. So the problem is that it really doesn't help us know that you're actively sick because of the delay in response. It's really not meant to be used in that way. So antibodies can tell us if you have been exposed to this, and we could use them at a later time, but they're not very helpful to us right now, and most of us have actually stopped using them as a diagnostic tool to know whether you're infected or not, because we have this other test. The other way that we're going to be using these antibodies, and the reason why it's really important for us to look at them and study them, is that this is the way that we can actually know if the vaccine is mimicking your body's immune response to the actual natural infection. And so we like to try and mimic that. So we like to understand what the body's reaction to the actual disease is while we're manufacturing vaccines. And we'll talk a little bit about vaccines in a bit. But this isn't something that we recommend for you to go out and get tested for because it's not very helpful to us at this point. The other thing I would like to point out is we're not sure if these if these antibodies, so your body's response, actually protect you from reinfection. It's only been shown in animal models that they may be protective. And as we're doing our vaccine studies, we are learning more about whether that will be the case or not. We also don't know how long they last. So if you were to say you were positive now, in a month later, we don't know if you would have high enough levels to actually be considered positive. So we don't want people to go out and also have a false sense that they're now immune to this and not take other precautions. So I did want to just go over a brief update on treatment and prevention of the virus. Your IBD physicians will talk about your specific treatment. We are learning a lot. There are medicines against this virus. There are medicines against the immune response, because even though, as I said, it's good to have immune response, some people have a hyperimmune response, and that's what makes them sick. And so we're learning to look for all that, and then we have medicines that could be targeted, some of which you're already on as part of your IBD. And there are some medicines where we can borrow other people's immunity and give them to people who are sick. So there's all sorts of medicines that we are learning about. And there's several new treatments that are being studied, including studied at Stanford, that look very promising. There is antibody therapy. I know everyone's heard about that. If I had the disease and then I got better, can I give my antibodies? We are not actively treating people with these outside of a study setting, but there has been some sort of variable results with it, with people, some people getting better, some people getting worse. So we're being cautious and trying to understand this more. The great news is that there is really warp speed, that's what it's called, development of vaccines. So we learned a lot from those other two viruses that were present and have been known to us for decades. So we learned a lot, and we were really actually able to find about 100 vaccine candidates very quickly. Remember, this has only been with us for 4 months. That's amazing. 22 of those have now been entered into preclinical phase. So it means they're understanding more about them specific to this virus. And actually 3 starting in July and through September are brought into phase 3, which is the phase in which we do large scale human studies to understand how they've done. So they've been proven to be safe in animals and short and small numbers of people, and now it's going into larger subsets. 2 vaccines, and now there's a third one that actually has moved forward, and they actually may be available as early as late 2020 or early 2021. And the good news is the way that this is being actually developed at this point, which is unlike vaccines of the past, is that it's a public-private partnership. So the public sector is taking a lot of the risk and said, just manufacture the vaccine while we're studying it. And therefore, if it works, we'll have a manufactured process. That's not usually the process in which people want to do this, but they want to make sure that if the vaccine is good and viable, safe and efficacious, meaning it works in people, that they will actually have a product. And so this is really the real main difference. They're not doing anything different when they're looking at safety or how it works. So those processes are continuing along the same schedule. So more to come on that. Will these be available to the immunocompromised population, so those who have inflammatory bowel disease? All conversations about these, because we know they're not going to be available to everyone, have identified people whose immune systems are suppressed from medication as a high-risk group, despite actually, and you'll hear from your providers, not a lot of disease in those individuals, thankfully, but you are slated on the list to get this as a first pass once some of our other very high risks, such as our elderly populations. And then we'll move through the populations as we go. So people who, also are in the front lines and things like that. In summary, most individuals do not have very severe disease or poor outcomes, but it's important to try and minimize your exposure. Shelter in place has allowed us time for better understanding of treatment options and development, but we know as it spreads, we really need people to continue some sheltering and effective mitigation, such as masks. Remember, the virus has only been with us 4 months, so we're really still learning, and it's changing, as Dr. Bensen said, and a lot of this is still under investigation. So I will stop.
Thank you so much, Hayley. We had a quick question in the chat that was, I think you were touched on it, just wanted to make sure that I heard you correctly. So what we're saying in general for IBD is that our patients, by being immunosuppressed and having chronic illness, do fall into a higher risk category, and we'd hopefully be considered a priority for vaccine eligibility. But as we're going on to here, or say that despite being in a higher risk category, in general, our patients do not seem to be having higher risk for more severe disease.
That is correct. And can I just add to that, please? The only thing that people need to realize is these are being studied in healthy individuals. So again, even though it will be prioritized to people that we know are high risk, or elderly populations and are people whose immune systems are suppressed by medicine, we're not studying it in that group, so we have no idea if they actually will respond the same way, if it will be protective. But we do want to allow these individuals to gain access. So just want to clarify that.
Dr. Goyal, did you want to go over these numbers for our IBD registry?
Yes, please. So go to the previous slide once, Megan. Thanks. So we have good amount of information on patients who have IBD and who've gotten COVID. So there are nearly 2,000 cases reported worldwide who've put their information on these registry. And we've learned a good deal from them. 704 are from United States. Only 131 are from the age group of 0 to 19. And just like Dr. Gans was saying, children are less susceptible, but we shouldn't become ahead of ourselves in thinking that. So next slide, please. So I put together this slide just to show you from this registry that of the 0 to 19 age group, 131 patients got it, and only 13% had severe disease. Severe disease just means that they were in the ICU or they required oxygen or extra support. And none of these patients died, so they all made it clear and they're doing well at present. And from the 20 to 30 age group, only 1% were hospitalized. And if you look at different medications, these are different medications. It's a very busy slide, so I don't think you have to go over all of them, but I just wanted to highlight that steroids do put you at a little higher risk of having a more severe disease compared to other medications. And here, if we look through each of them, they are pretty low risk. And here is your Remicade, Humira, and see that only 2% of these patients had a severe disease. When you are on a combination of Remicade and either methotrexate or Imuran or 6-MP, the risk becomes a little bit higher. And if, like here, you would think that methotrexate is causing a very high risk, but only one patient on methotrexate had to receive ventilation, so it looks like a high percentage, but it was because the number of patients who were only on methotrexate who got COVID were 13. So this slide basically represents that our patients who are getting these medications are not on extraordinary risk of developing serious disease, especially children, and they should come out fine if they were to get the infection. Thank you.
I think we're going to pass it to Dr. Chen to talk to you a little bit about some back to work and school recommendations, since I know that several of families are facing this issue.
Thanks, Dr. Gans. I too am dealing with these types of decisions about back to school. And I think our best advice at this point is to learn a bit about what that school and university is doing to try and mitigate against infection, reduce the possibility of infection for your child, the student. If you can go to the next slide. And what are those things that you should learn about? There are things that you already know. If you go to the next slide, these are things that you are already doing to mitigate and decrease your risk of infection. And I have a whole series of images here. This will be a little test for you. See if you can decipher what each of these images mean. Give you a few seconds. So if you go to the next slide, Megan. So these are things you already know and already practicing. So know how it spreads, wash your hands, avoid close contact, wear a face covering, cover your cough and sneeze, clean and disinfect, monitor your health. And the same things that you do as an individual to mitigate your risk of infection, you can then learn about what that K through 12 school or what that university is doing. Go to the next slide. And the CDC has given them some fairly detailed guidance as to how to deal with each one of these little images that I showed you here. So for example, how are those institutions conveying knowledge of how the virus spreads? How are they teaching the students about it? How are they promoting healthy hygiene practices? How are they promoting social distancing? How are they intensifying cleaning and disinfection and ventilation? And then how are they monitoring and maintaining healthy operations? And do they have a plan if a student or a instructor becomes positive? And I think as you learn about those ways that they're mitigating against infection, then you will, as a family, have to weigh those risks and benefits. And of course, you can talk to your team of coordinators and physicians to perhaps help you make that decision. The last thing I would want to point out is that if this is a university that you're thinking about, you should take some time to see what the rate is of circulating virus in that particular geographic location, that particular state. Because if it's a rapidly increasing rate at this point, and most schools and universities are starting pretty soon, you will want to be careful. If you choose to allow your child to go to this particular university, just be sure that you are planning of what you're going to do if the university then has to close down. So think through all of those particular steps. The next slide, I think, is more of just an example of the things that the CDC has provided to these institutions to think about in terms of all of those little images of ways of mitigating against infection. Thank you.
We might, just a quick addition, that was so helpful, Dr. Chen, and you talked a little bit about how this virus spreads, and I alluded a little bit to this coming through the mucosal surfaces. So I just did want to quickly let everyone know that there are different ways in which this virus spreads. So if I am infected and I am talking or don't have myself covered, I can spread that virus to people who are in close proximity to me. And when I cough more forcefully, maybe somebody a little bit further away, which is hence why the 6 foot sort of designation came into being, because as the virus comes out of me, it's in these what we call droplets, and they actually drop, but they obviously can be projected. And if they land on me and my mucosal surfaces, then I can become infected. The other really important thing that people need to still pay attention to, and Dr. Chen really spoke about this, is surfaces. So if I'm infected, again, I don't have my mask on, I go to the bathroom, I cough all over the sink, I touch the doorknob. I've now contaminated all those surfaces so that once I leave the bathroom, you have no idea if I was there or not. And then you want to enter the bathroom, you've touched the knob, then you touch your mouth or your eyes or whatever, and you become infected. So it's surfaces as well as contact with people. So that's just something to keep in mind and to provide that information to your students. That's why hand washing is so important, and while masking is so important because it just keeps our environment with less virus around. The students should clean their workspaces too if they're entering and they have no idea. And trying to eat in places that are outside where other people haven't eaten or in their own rooms or whatever it is probably the best thing.
Would either of you be able to speak specifically to college living situations? Because I know that a lot of schools in California are going to full distance learning, but there are still some of our patients who may be traveling out of state to attend college.
Was there a specific question about that?
I think just general precautions when you're, as different states have different recommendations, maybe just underscoring that.
Yeah. Well, my child goes to college in Chicago. And so several of my friends also are sending their children to Colorado, to Boston, to other states. So as Dr. Chen said, I mean, we're trying to understand what's happening in those states. There is, if you go to Corona Tracker and you go into the Johns Hopkins site, you can actually see which states are flattening the curve. So if you go to trends, it will show you which of the states. So many, many states are starting to flatten again. I know at least for my university, as Dr. Chen said, I'm able to check. They list all the positive cases. And so you can see what's actually circulating on campus. Now, of course, there's summer and there's not many people there. They have a large international group who has remained. So, you know, some evidence. A lot of universities, I would say most, are actually offering singles to individuals who are coming to campus. So that's something to request. You can particularly say, we're from outer state. So, you know, if my child gets sick, they can't just come home and quarantine. So they would need a place to quarantine on campus. So schools are offering those usually at no additional cost to the families. So that is an effort for them to keep social distancing. I would also check the bathroom situation and really educate your student. Is the bathroom inside the room? So it's your child's own bathroom. Is it something they have to share? And finding out like how many people are on the floor and how many people are sharing that and how is that being monitored and cleaned? And the last thing to also realize is how they're doing food. So most universities are now doing pickup food, like there is no cafeteria service. And so all meals will be available to children to come and get, and then they should take them somewhere again. I'm not in favor of outdoor dining spaces because you know, if you take your mask off and sit there and eat, and then the next person comes along and sits there and eats, it's obviously a contact issue. So I would just recommend that your child find somewhere where that situation, where there's not group activity happening. So multiple people eating at the same tables, but they should at least be outside. You should direct your student to try and eat in places where other people are, you know, haven't been at that table. Classes are probably going, well, in person, they will probably still be hybrid. You should ask how many students are actually going to be in the classes and how they are preserving the ability to keep them separate. Most universities are also doing universal checks. So my student actually has to do a symptom check daily and record that on their student portal. So you can ask about that. And in addition, our university is also offering free testing for all the students. So I would find out about that, because if your student is feeling ill or was exposed and feeling nervous about that, figuring out if that's accessible to the student. If not, try and establish care with some provider so that that can happen for your student. That's all I can think of, Sharon.
No, I think all
Can I
those,
interrupt for just one
Yes.
moment? One of the families brought up a really good question on the chat earlier, and just wanted to highlight that for everyone, that as your college age, if you are listening and you are students and or college age children are over 18, that a great idea is to have them think about whether you'd want parents to be able to communicate with the medical team directly. And so if you do, to fill out a release of information so that we can communicate with your providers there, or your parents can communicate and help coordinate for you in case things get a little bit, there's more questions, or we have to change where you get some of your care, or while you're away at school. So we can help, we have forms for that, and we can help you fill that out. And another great question, yes, even if you are out of state, you can most certainly continue to communicate with us. We are still, unless you've transferred your care somewhere else or stopped answering our phone calls, we are still your doctors, even if you have gone away to college. That's generally our policy. We're happy to continue communicating with you. There are some restrictions about us being able to either prescribe you medication, so we can't necessarily prescribe your Remicade infusions out of state. So you need someone else maybe to do that, or some states allow us to do telehealth visits with you when you're out of state, and some states do not. It's a lot more free and open during COVID times, but there are still some restrictions, but we are more than always able to talk with you, guide you through your symptoms, help you access care, help you figure out how to manage your health and your IBD, regardless of where you are.
And another question which was really good on the chat was whether we should get flu vaccine. So I'm like, I think that is absolutely yes. The timing of flu vaccine. So I would like Dr. Chen and Dr. Gans to weigh in as to what would be a good time to get flu vaccine this year.
Yeah, thank you for that question and for allowing us to answer that. You definitely should get flu vaccine, and we would continue to recommend that all family members get the flu vaccine this year. You do not want to be ill and come into care at a center for us to be confused whether you have flu or COVID. These are going to be co-circulating, so it will confuse us. We also don't know if you get flu and you get corona, are you actually going to have a more severe illness? So please, everyone get the flu vaccine when it is available. Fortunately, it's probably not going to be available before your students leave. And so that's another really great thing to make sure you understand how they can get their vaccine. Most drugstores will actually carry, it's very easy for your child to take their insurance card and go and get the vaccine. I even, so all of our local CVS, Walgreens, I mean, I don't know what's available where your child is going, but all that is a viable way in which your students can get it. Earlier than later would be great. We don't know what's going to circulate this year. We never do. And the circulation times in other states is different than California. We're a little bit delayed beyond, like it usually starts in the East Coast. So if your child's going there and then moves across the country. So please do get it when it's available. It's usually available in September.
And for those of you who are get their infusions here at Packard, or who come to clinic in person, and we're still continuing to do a lot of telehealth, but if you are having in-person visits for whatever reason, we anticipate that we will have flu vaccine in clinic as we usually do. And we also can give you the flu vaccine in the infusion center at the time that you come in. So we'll still be able to do those things as we normally do.
So I wanted to thank Dr. Gans and Dr. Chen for the wonderful overview, but I wanted to ask you whether, you've given a very good overview for college students and older children who are more responsible and can follow these guidelines. But many of our patients are younger children, and their parents may have to go to work. What are your guidelines for say the younger children, less than 8 years old, who don't always listen or follow the rules?
Well, I mean, that's a great question. And right now, I think our recommendations are that you follow what your county public health department is telling the school systems in that area. So, for example, most of the Santa Clara County K through 12 schools are all virtual and all online right now. And I am not up to date of all of the counties, but I think the answer is you will need to follow what is going on with the local school district in your own county. And we'll see, things change, but we'll see how it goes through the fall.
Yeah, the only thing I would add is some creative ways in which people are doing daycare is to pod young children, so that young children will all be together in only small groups, and then only have one individual caring for them. So if somebody were to get sick in the pod, they know it's a very small group of people that needs to stay home and quarantine or get tested or however it is. People have since daycare centers are maybe not working at a capacity, there are child caregivers in the area who might be able to come together, and if you want to form groups with families or other ways in which you can sort of pod these young children. In terms of following precautions, we don't recommend masks for very young children. They don't tolerate it very well, and they don't use it very well, and they touch their face a lot because the mask is bothering them. However, it does actually cover their mucosal surfaces. So if you feel like you're going into a high risk situation, which like small group daycare is not, then I would try and talk to your young child about wearing it for whatever transient period of time and not playing with it, because it does kind of protect them. So travel, things like that. I think washing hands is a great thing, particularly to make it a real habit and do it with your child when they come into the home and before meals. Get them used to alcohol. Most of them don't like the smell, but get used to it. Again, alcohol kills what's on there, but doesn't get rid of the dirt. So children naturally are playing a lot and get dirty, which is a great thing in the normal time because it's actually how their immune system gets educated. But getting rid of the soilage with soap and water, and then you can alcohol after that if you want. Or I always put in alcohol, one of those little tubes on my kids' backpack, so they always have it accessible to themselves. I wouldn't think that I wouldn't count on other people having it, just trying to make them aware.
I think,
it's a challenge.
as the winter comes, and especially it gets drier, being attentive to skin care too, like moisturizing your hands and stuff. I know, again, just in my own personal experience with my children, they were so conscientious for a period of time that they had cracked skin that burned, and I think also just continue to make it easy for them to adhere to those hand washing guidelines. Yeah.
I've seen a lot of great videos online that you can always sing different songs, and it makes it fun when kids get to wash their hands with their parents. So you can try and make it fun. Maybe they'll be more willing to do so.
I wanted to, that's all great information. I wanted to go back to what Rachel was saying about preparing for college-age kids going away and out of state, that if you had infusions, clearly it's going to have to be written by somebody else in that particular state for the new infusion center. But those getting things like Humira or prescription meds, you should also prepare, because some states don't allow us to prescribe. And so it's a matter of arranging with your pharmacy about whether or not they can send out of state. And if not, then trying to figure out how to work it so that the student gets his or her medications consistently, especially things like Humira that need to be refrigerated.
Can this group discuss whether you will be doing telehealth availability for your out-of-state students We've been doing that with some of ours. I think it's available now. Telehealth didn't used to for out of state, but I think we've expanded that. Do you want to comment on that?
Yes, we will be doing telehealth for our patients. Whether they are here or out of state, we will definitely be taking care of them.
Yeah, I think
And
whether it's via phone calls or whether it's with formal telehealth visits or routinely or some combination of both when you're back here. The rules seem like they keep about what we can do as a formal visit seem like they're kind of an evolving and moving target. So we'll continue to stay as up to date on that part as we can, but we'll continue to be seeing you and following up as needed.
And I also wanted to emphasize one important thing that, we are afraid of medications that we use for IBD, but what we've seen is that if the IBD is not under good control, your risk of having more severe disease or more severe outcomes are far more than as I've shown you, the medicine itself is not posing that much of a risk. So please do not be afraid of the medications.
And I think on that note, just wanted to give one last final comment that our IBD Center is continuing to grow. For those of you that don't know, so here on the call, we have Nicole, who's our research coordinator for IBD. At some point, you may be interacting with her. We have Lisa, our new IBD nurse, who is full-time working with IBD and celiac. We have a new clinic coordinator, Kristen, who's not on with us, but she just started this week. And so she's learning the system and will also be another resource for you. A new social worker who will be helping us, who's Garrett, who's fantastic. And behind the scenes, a new person who's helping us organize our data and documentation and our center quality improvement projects. So we are thrilled to be having this growing team and be able to continue to grow and build and do more for all of you. In that vein, we also have been having some virtual mindfulness events. So we have another one coming up and planned for September. So we will be in touch. If you don't get routine messages from us, you can email Megan at her email address is on the screen and she will send it to you. Probably if you are on this call, you get messages from us, but we make sure if for some reason you are not, please let us know so we can make sure we communicate with you. And thank you again to all of those on our panel, our call, and our infectious disease partners for all of your hard work with us.
Yeah, thank you, Rachel. I think we have a little bit of time. I was wondering if Dr. Wren could come and give a few words of how to cope with this stressful time. I know she has given her advice before, but I think it's never enough. Is Dr. Wren there?
Yes, having some technical difficulties.
Okay. So can people raise hands as to who all are having difficulties with coping at this time, especially with younger children and teenagers? Let's get a count. You can use the reactions and raise hands.
We have at least 3 raised hands. I'll raise my hand as well.
My hand. I'll add to it.
I'm sorry, I was going through some of the chat. This is Dr. Gans. I did want to point out that the vaccine is not live, but it's not it's not taking the virus and inactivating it. There's a lot of different formulations, but a lot of it has to do with the genetic material and using that to stimulate our immune system. So it's a great question. Thank you for reminding us to cover that. It's not something that would be harmful to people whose immune systems are suppressed. So thank you for bringing that up.
Dr. Wren, you're muted. I think she's still having.
Yeah, I think we're probably going to have to leave it there, but everyone knows that if they need specific consultations with Dr. Wren, they can reach out. And obviously our team is always available for any of you who need, wherever you may be.
Hi guys, I'm so sorry. I am having some technical issues. I am in a different location than usual. But yes, we're almost wrapping up, but I am so happy. I'm not sure quite, Megan, what you just said, but I am so happy to meet with people one-on-one, to have a consultation, to talk about coping and stress. And this is it's a challenging time. And that is why we are wanting to provide these community events, these town halls, these mindfulness series to provide some stress management tools, connecting our families with IBD to each other virtually right now. So please be in touch if I can be of any assistance one-on-one, and please do join us for the series that we've been starting, which is the holistic, thank you, Megan, for bringing attention to this, with the holistic healing for IBD and the virtual mindfulness series. And we will continue these series in the fall. So do stay tuned and join our listserv if you're not on it. And thank you guys all again. Thank you, Dr. Gans. Thank you, Dr. Chen. Thank you, our team. Thank you, everyone, for joining for this third town hall. And please do give us feedback if you have any, letting your provider know or emailing Megan, or if you have things that you would like us to discuss as the summer ends and we go into fall. We are absolutely happy and open to continuing these town halls. And we are just here for you guys and whatever you need. So just please do be in touch. And have a really good evening, everyone. Let's see if there's any last Q&A before we log out. But thank you guys for your feedback, really helpful. And we do plan to continue these. Okay. Bye, everyone.
Thank you, everybody.
Thank you. Take care. Be safe.